Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by
All
anybody.
right. So, good evening, everyone, for this class today. And I'm going to start with the session on discussion of paper number 2. This is this DNB October 24 paper number 2. Let's begin. So the first question that was asked was discuss the diagnosis of unruptured ectopic pregnancy. When they ask you about just the diagnosis, remember that you have to stick to just the diagnosis. All right. Now, I want everyone who's there in my class to quickly tell me in how many ways can you diagnose a unruptured ectopic pregnancy? Tell me everything that you would need to come to the conclusion that it's probably an ectopic pregnancy. It's a very, very easy question. You'd see it in day-to-day life. Come on, guys, start writing. In this way, you will remember. You will remember much more than what my mundane class can teach you if you keep answering. And let me just check on my chat messages so that I know what you guys are answering and I can add on to it with my PPT. So everybody who's asking for my PPT of my class, guys, remember that these are PPTs which are added automatically to the answer bank. Okay, so these live classes are being added every day to the answer bank, and you will get these classes only if you take the answer bank. All right. Yes, so I have the answers with me now. My students are answering that. First of all, history, right? So she's missed a period, all right? That's very, very important. Then pain. She gives you the history of pain, left side, right side, sometimes in between, okay? UPT is positive. One more. Now the tests have started coming in. More than that, what about the examination? So you're finding bogginess or you're finding tenderness in one of the fornices, correct? And then you went on for tests. So beta HCG is not doubling. Okay, ultrasound is not showing a sac intrauterine. And then the diagnosis is slowly formed. Isn't it, guys? Okay. Yeah. So let me just quickly tell you, you are right. All of you are right. Usha is right. Harsha is right. And all of them were there in the class. I like to just ask everybody to keep writing down. Rupali is there. Meghna is there, right? Shrishti is there. Chandni is there. Umesh is there. Amarjit is there. Please, guys, keep answering. I know that you people are there in the class. It's a very, very easy question. You will enjoy answering, guys. So please keep answering. And yeah. Lots of good answers. So definitely first will be a clinical suspicion, right? Certain risk factors, very important are risk factors. If she gives a history of, let's say, chlamydial infection before, or a PID before, or a previous ectopic before, you are always ectopic minded, isn't it? Then she's giving a history of missed periods along with pain, lower abdominal pain with a PUPT positive, okay? Or vaginal spotting along with abdominal pain. That triad of ectopic pregnancy, missed period, that is amenorrhea along with spotting along with pain abdomen. What is that? There's a classic triad of ectopic pregnancy, right? So she will give you, okay, no, I had a period. I did have a period, but I'm having pain as well. The pain is just not going. It's very excruciating pain. So ask, what kind of period did you have? It was only vaginal spotting, or was it a proper frank period? So the period got delayed and I did have a period, but it was not a normal period. It was just spotting. That means she never had a period. It is still going to be called as amenorrhea. Okay. And then on topping of that, history of PID or chlamydial infection or tubal surgery or, some ectopic pregnancy before, that is clinical suspicion. That's number one. So that comes from the history. Then when you examine her, okay, that part should also be here, when you're examining her. So if you find any pain or bogginess in one of the fornices, that's one added on thing. Then you go in for the investigation. So beta HCG, single beta HCG insufficient. So you need serial beta HCGs, all right? So if they're not doubling up, that means you have to be ectopic minded. And the second, a very important thing is ultrasound, the transvaginal ultrasound preferably. So you're going in for a transvaginal ultrasound, you should be able to see gestational sag once the beta HCG is above 1500, right? But if there's no intrauterine pregnancy above this threshold, ectopic is suspected, correct? Transvaginal ultrasound, once you see, an intrauterine sac, you kind of exclude. But sometimes even in transvaginal ultrasound, you can see a small mass, correct? Then, of course, serial beta HCG monitoring is very important. They say progesterone testing is not so important. Physical examinations coming later, it should have come earlier. Use of diagnostic laparoscopy is very, very, direct visualization can confirm the diagnosis. And there is obviously an importance of early diagnosis. So actually your diagnosis is made by history, examination, investigations. So we have talked about all of them, correct? All right. Now there was a question that there's a 30-year-old girl, okay, 30-year-old female. She's G2P01, that means she's been through an abortion before, is 11 days overdue and asymptomatic. She's reported in your OPD with endometrial thickness of 8 millimeters and she has a beta HCG of 836. Discuss her management. So it's very clear that she's overdue, right? She's got amenorrhea. She's got no symptoms. And there is endometrial thickness is 8, but her HCG is 836 and she's just 11 days overdue. So she's yet not, gone to the threshold limit. We talked about the threshold limit, isn't it? Over here. Discriminatory zone. She's not yet reached that. She's just 836 beta HCG. Only if it is 1500, that means if it doubles up 1500 and above, she should be able to see an intrauterine gestational sac. So what will you do with her? Discuss her management. So again, when you start with the management, guys, what do you start with? Tell me that. Whenever I talk about the management of anything, you start right from the history. Okay, so you took the history. This is the history. She has regular periods, very important that you need to find out, okay? And once her periods have been regular and she has been overdue since 11 days, okay? And her beta HCG also are coming positive. Yeah, then you go in for this thing examination. Then you go in for the investigation. So currently there is no symptom. She's asymptomatic. So what you see is through a transvaginal ultrasound. But in ultrasound also the findings have been given, right? That endometrial thickness is 8 millimeters it's on a TVS, right? So in this case, what you do next will be you have a DD in your mind. Guys, can you quickly tell me what are the DDs that are coming into your mind? Is it ectopic only, or could it be anything else? I'll need to see your vision. Everybody, quickly write down the DDs. What's coming in your mind? Okay, one is the missed abortion. You feel that there's a missed abortion, but she's not yet started bleeding. Is it? Okay, Shrishti, I can see your message as well. Okay, yeah. This is the way you go. Now tell me the DDs as well. Okay, yes, Usha, great. Arsh has given me one of the DDs. What about the other DDs? Think about it. If it's a missed abortion, so then that case, she's not yet had any gestational sac made. So you can call it either a failing pregnancy, right? So what about others? Tell me what others? One is definitely ectopic is coming into your mind, right? One is failing pregnancy. What else? Yes, guys, come on. What do you think is a possibility? Very good. One could be a pregnancy of unknown location. You don't say ectopic, you just say pregnancy of unknown location, which is also, a way to call ectopic pregnancy. Yes. Chemical pregnancy, agreed. Absolutely agreed, Deepika. It could be just a chemical pregnancy that the beta HCG has gone high and it's not. And could be, don't you think it could be very early pregnancy? You've got it too early. Maybe it was a late implantation. You never know, right? Maybe it's wrong dates. She doesn't remember how overdue she is. So it could be wrong dates. So these are the DDs that come in my mind, all right? So I'm thinking about maybe it's wrong dates, maybe it's late implantation, maybe it is a normal healthy pregnancy, but we need to wait for a day or two till the HCG level doubles up. Maybe it's a failing pregnancy, maybe it's a pregnancy of unknown location. So these are the things which are coming in my mind. Absolutely right. All my girls are very, very intelligent and they have a DD better than mine. So an early intrauterine pregnancy, maybe too early to visualize a sac, or a failing intrauterine pregnancy, or a pregnancy of unknown location, or an ectopic pregnancy. This is the same thing almost. Okay, guys, you were all absolutely correct. Excellent. So this was the DD that was coming into my mind. I'm still left with the management. So how will you manage this case? First of all, you have to confirm the history, correct? So confirm the LMP, confirm that she remembers the dates correctly, confirm that she had regular menstrual cycles. Very, very important. When did I say in the question that she had regular menstrual cycles? Maybe she's a PCOS case, maybe she has delayed cycles, maybe her cycle, she's 11 days overdue, but she usually is 7 days overdue. So for her, it's just 4 days overdue actually. So very important is to take her complete menstrual history. Okay. You confirm the LMP. You evaluate if there is any risk factor for ectopic pregnancy. You confirm that her cycles were regular. Okay. You take a complete menstrual history. You perform a pelvic and general examination. You note for any adnexal tenderness or any adnexal mass. And then you go in for a beta HCG monitoring. If it doubles up or it is more than 60%, then probably it's a successful pregnancy. It's a viable pregnancy, and you ask her to come for an ultrasound 7 days later for a TVS. If it is decreasing, the beta HCG is falling and it's falling more than 50%, then probably it is a failing pregnancy, which was never seen, chemical pregnancy like you all are talking about. But if it's anywhere in between, the beta HCG is increasing, but not exactly doubling up. The beta HCG is falling, but not exactly more than 50%. There you have a vision. There you think about either an ectopic pregnancy, pregnancy of unknown location. This is what is coming in your mind. So beta HCG monitoring is very, very important. And then repeat the transvaginal sound. Like I just told you, discriminatories on the moment it's 1500 cross beta HCG. Please look in the TVS if there is an intrauterine gestational saccharon, because just in case it's not, we are looking forward to a pregnancy of unknown location. Okay, uncertain location, ectopic pregnancies. Follow her up for any signs and symptoms. If she's got acute bleeding, acute pain, then in that case she has to be on a complete direct vigil. Okay. So if she's got bleeding or dizziness or nausea or, sudden shock, pain, abdominal pain, or she just, collapses, you have to be on a lookout for all these dangerous symptoms and always be ectopic minded. Counseling, documentation, psychological support, these are, just add-ons. But the actual management is what we talked about in the first 2-3 slides. Okay, guys? And timely intervention involve a multidisciplinary team. Then definitive management options in detail. So suppose if it's a viable pregnancy, what will you do? You'll go in for a routine antenatal care. That you can write down, I'm sure, better than me. If it's a non-viable intrauterine pregnancy, then you have to do either for expectant management, medical management, surgical management. Okay, this is a question separately asked also, guys. You remember that? Well, question is asked how to manage a case of missed miscarriage, missed abortion. So expectant, medical, surgical. You have to go for this, correct? Then if ectopic is confirmed, I don't know how many times this question has been asked, medical management versus surgical management. So if she's hemodynamically stable, the size is small, beta HCG is less than 5,000, she can go for a medical management. Otherwise, she'll go for a surgical management. She can even go for an expectant management if everything is, even the beta HCG is even less than 1,000. She can go for